All right, I think we can start. So just a real quick reminder before we actually begin. Again, if you want to go to the app, find the session, you might have been prompted when you walked in, and participate in the poll. And again, we have the white papers here in the front for anybody. There's also an option in the app where you can download the PDF as well. Okay, so you all ready? Okay, wonderful. So first of all, I want to thank everybody who's here in this session, because I believe this is maybe the 4th prior auth session, and you're all here, and I'm just, yes, exactly, right. So this is going to be like a culmination of, 3 sessions worth of what are we going to do differently in prior auth. So I'll start by introducing myself and then, our fellow panelists here. So my name is Eduardo Garcia. I'm a partner in IBM Consulting, and my background is in innovation strategy. I work with our large payers and health systems to help them understand how to leverage new technology and also how to modernize legacy systems. And I also lead IBM's strategy in prior authorization. And Heather, I'll pass it over to you.
Hey everyone, I'm Heather McComas. I am Director of Administrative Simplification Initiatives at the American Medical Association. I'm in our health policy advocacy larger group, and my team works on reducing burdens for physician practices, and prior authorization tops that list. So really glad to be here today.
Hi, Kevin Larsen. I'm a physician and internist, and I lead a team of clinical informaticists within Optum. We're building point-of-care solutions that are EHR agnostic and based on FHIR to bring clinical recommendations into the point of care. In a prior life, I was at CMS, and so have lived a world of prior authorization and actually been part of Da Vinci all along. So happy to talk.
Great. Hello, everyone. My name is Tamkeen Rasool. I am a partner at IBM with IBM Consulting. My background is in healthcare, but more cross-entity, if I want to call it. So I worked in payer side, provider, retail health, and at IBM, I lead data interoperability, data analytics, and now the new AI. So very a generalist in a sort, but it comes in very helpful when you're actually looking at different entities across healthcare, because to many, what we know is obviously it's very federated. So very excited for this discussion today.
Thank you. So just to ground ourselves a little bit, so of course we're going to talk about prior auth, but we're going to talk about it in the context of, what's new, right? Obviously there's new solutions, AI, interoperability, but kind of what happens next, what comes next. So with that being said, I want to start by maybe kind of grounding ourselves a little bit in the present. I know many of you are responding through the app, and I want to ask our panelists to name one thing that is working and one thing that is not working in prior auth.
Well, we had a prep call, and I warned you about this, Eduardo. So I'm speaking on behalf of physicians, and if I said that there was something working about prior auth, I would lose my job. I had to close the business today. I mean, it's a huge problem for our members, and certainly I think, we're at a technology conference. We're going to be talking a lot about burdens and workflow, but really the reason this is such a hot button issue for physicians is it impacts patients. I think the term and phrase moral injury has come up a lot in recent years, describing the impact of prior authorization on physicians. They see every day how it's interfering with their patients getting the care that they ordered, and it really contributes to burnout. It's an emotional thing. It's not just, oh, this is such a pain, I'm spending time on it. It actually hurts them emotionally and mentally. So I gotta say, I'm not sure what's going right, but the thing is going right is we all are here talking about it. At least we all are prioritizing this. So that is the thing I'll say is going right.
Yeah, what I'll say is going right is we're investing finally in different kinds of automation. So the investment in the Da Vinci prior auth implementation guides is a huge step forward. We're investing in models. We have one at Optum. Other places are investing in how to do this in a new way. What isn't working? Most everything else. But I think what I'll call out specifically, I've been in the space of building rules to do automated quality measures and automated clinical guidelines. The prior authorization guidelines are not ready for automation. I can just tell you, I've tried for 25 years to automate the oxygen prior authorization guideline from CMS, and the data requirements are so challenging. Was this patient 2 days before discharge, on room air, not having exercised, and what was their O2? Impossible to pull that in an automated way from the record that is reliable. And so we have a rules question to really ask ourselves if we want to continue down prior authorization, because those rules are not ready to automate.
Yeah, and as a technologist and healthcare enthusiast, I think what's working is we are finally talking about prior auth with keeping new technology in mind, and these conversations are happening, and we're actually thinking about applying latest and greatest technology to solve this problem. And what's not working is probably everything we've spoken this week about this. It's the lack of standardization, not knowing what rules to follow. And really, I think there's this one question that we need to talk about when we talk about prior auth is, are we shifting the workflow burden from what we have right now to something new with a new enabler as a technology, or are we really solving the problem and reducing the waste? So that's really what the problem issue is.
Yeah, and those that's what we're going to talk about. But I want to take an opportunity to look at the poll. So what is working today? Nothing. Don't know. Data exchange, regulation, data sharing, auto approvals, not much. Inpatient stays, NCPDP, okay, RTBT. That one I need to remember what that one is. But I know that we imposed the 15-character limit, so it's our fault. The second one, what's not working? Real-time information, policy transparency, delays in care, standards, attachments, timely approvals. And I forgot to ask one more question. Do we think we're on track for the 1/1/26 CMS deadline? And overwhelmingly, the answer is no. So I'll just ask if you would concur with that answer. The 1/1/26 CMS.
Again, from living through a lot of CMS and ONC rules, we were never on track for any of them. And we kept hearing, and when I was in government, we kept hearing from industry publicly, hey, don't make us do anything. And privately, they would say the only way we're going to do something is if you make us do it. So didn't ever quite know what to say there, but we would get two different messages. So.
And that being said, of course, we want to balance the positives and the negatives in this session, so it's not all about, what's not working and what we can't do, et cetera. But one thing I did want to mention, because I've sat through the sessions this week. Yeah. Okay, like that? Okay, got it. So the whole effort from Massachusetts, right, to take that from a market perspective, I think we've seen during the week some examples of innovation. So I want to encourage us to balance sort of the art of the possible and where there's some bright spots with obviously the challenges that I think are well known and that we'll discuss a little bit. So with that said, let's dive into the deep end of interoperability. So you mentioned Da Vinci. Obviously, interoperability is at the core of enabling the transformation of prior authorization. But as we saw this week, right, we're still struggling with the adoption of the standards. I think the presentation we had from the SDOs really brought that to the forefront of all the different perspectives and how the SDOs need to collaborate with each other, the standards organizations, that is. And I thought the working groups on Monday also did a really great job with how each payer presented, here's where we're at, and here's what we have, here's what we don't have, here's some of the challenges. So I like that we have a lot of transparency in that regard. But that being said, if you were somebody who sat outside of this room, outside of healthcare, maybe you were a banking CIO, and you saw what was happening with regards to prior auth and the issues with the standards, how would you explain, how would you say, maybe they're scratching their head thinking, what are you guys doing? How would you explain some of the complexities that we've seen around the standards and the adoption of the standards. And I'll go to Tamkeen with that first.
Yeah, I think banking is a great example because anytime I think about interoperability within healthcare, I think a good example is the financial industry, because we went from paper checks all the way to electronic, but it went through the same evolution. We really haven't seen that in healthcare because obviously it's more complex and it's patient related, so the leapfrog has been slow. But if I am to explain this to someone who's not from the industry, I think there's a lot of obviously standardization, and then the attempts for us to have standardizations over time. So we have EDI networks, we have FHIR standards, we also have NCPDP. So how do you reconcile all of these to create one holistic standard which is being honored and followed? And a lot of this will come from regulation. So to answer your question, I think there's a lot of confusion with standardization and how to enforce it. And the easiest way is for a regulatory body to implement it. And what CMS is trying to do, what ONC is working towards that, are the steps in the right direction.
Yeah, I would say that, so we as a company have been public about decreasing the volume of prior authorizations. So this isn't just about the automation, it's about like where can we just eliminate? One of my favorite articles in the last couple of years is in something called reductive innovation. How is innovation getting rid of stuff instead of adding more? And when I was at CMS, we had letters from large provider organizations and professional societies about that high volume of prior authorizations that were won on appeal. We have a whole waste in this system that we can get rid of that we don't have to automate. And if we don't actually get rid of it and automate it, it'll become invisible to us, but it'll still be this churn. So let's get rid of a bunch, and then let's focus on automating the rest that we believe that we need to automate.
Yeah, I want to pick up that thread of getting rid of some, because I think a lot of our discussion here this afternoon and throughout this conference is just the sheer volume and the sheer volume of rules across payers that need to be codified. And I believe we can keep on going through our cycles of the brand new shiny thing every 3 years, and WEDI, there would be the next magical thing 3 years from now if no one actually does the work. And part of that, doing that work though, I think is gonna be tailoring down what we're actually applying this to, because otherwise the amount of work is just way too much. So that's definitely gonna be part of it. And I think also too, I totally agree, Tamkeen, we do need a mandate and some kind of regulatory action to get us all moving in one direction, but also we need to be sure, I think, before that lever is flipped, that we know it's going to work in the real world, or we're going to be in another situation where we have something like, there's been this idea of attachments floating out there for how many years and never got implemented because we didn't, there are some cases of it being used for claims, but not really for prior authorization. And so being sure that this works in the real world, out in the wild, is really important, or else no one's going to really adopt it at the end of the day.
So I want to pick up on that and ask you about, because of your background in pharma, right? So when we compare pharma versus medical, how does that, what is your observation on, in terms of their efforts to automate prior authorization versus what we're seeing in medical, and particularly the standards, NCPDP
Yeah,
and such?
so first of all, I think one important element of that, and is something that definitely applies to the Da Vinci work, is that process is embedded in the EHR workflow. It's in e-prescribing, right, as part of the physician's workflow. And I think whether we're talking about prescription drugs or it's medical services, there's kind of three basic chunks in my brain of the prior authorization process, which aligns with the Da Vinci guides. But first of all, I need to know when I'm ordering or prescribing, does this require prior authorization, right? And then that on the prescription side, it happens in the EHR, and that's the vision for Da Vinci, right? The second thing is, I need to know what data the payer needs, right? And that's part of the EPA questions, that it comes back to you. Answer these questions. Ideally, those are auto-populated with data from the EHR. And then there's the exchange of data back and forth with the payer, and the payer says yes or no. And so it's the same basic vision, right? And it's in the prescriber's workflow. And the whole idea is you get that taken care of before that prescription goes to the pharmacy, before the service is ordered, so we're not delaying care.
Perfect. So we're going to take that and decompose it into two. The first part is going to be technology, and the second part is going to be about the, what happens when you're in the workflow. So let's talk a little bit about AI and automation. That's obviously been a theme in everything that we see in terms of new solutions for prior authorization. And the business case for AI and automation is abundantly clear in terms of the possibility of the ROI and how many hours and so on and so forth. But despite the fact of all these business cases that we see, there's a bit of a gap between sort of the advertised benefits and the reality when you actually go and implement that. And we are still seeing, of course, low adoption of EPA, and I think that came up, I can't remember if it was earlier today with the CAQH chart, and it's obvious that we're not where we need to be with regards to EPA, and ultimately the levels of efficiency that are achieved are relatively low. So with that in mind, I want to ask, what is it? Is it that the business case is not right? Is it that we're expecting technology to sort of magically solve everything, and maybe we're placing unrealistic expectations in technology? Or what's the rub? What gives? So I want to go to Kevin first with that question.
So big fan of e-prescribing, worked a lot with NCPDP and those standards as well. I think one of the things that exists there is a monopoly, SureScripts, that actually manages a whole bunch of the endpoint. And I think we don't have that, at least I've never found it, on the medical side. And when we try to give our providers, so Optum Care providers have about the same amount of United Healthcare insured patients as a general another provider would. So we have about 13% market share, so our doctors see about 13% UHC patients. If we give them a UHC only solution, they won't use it. They're like, this has to be the same for every single payer I have. And especially because so many payers are state-based, are so many payers. And the complexity of managing the payer endpoints with their eligibility and with the different plans they have is so hard and complicated. But the providers need, if they're going to do this, they need an all-payer solution that manages this for all the payers that they're interacting with.
And I want to go to Tamkeen with that as well, because we looked at in fact, we have a white paper as well. This is the third in a series for interop, but we looked at sort of what's the ROI story behind interop. So maybe you want to talk a little bit about that.
Yeah, I think the ROI story is very compelling because we did just back of the envelope math on what is just the gain and annually, and for a mid-sized payer, it was between, I can't even remember exactly, but it was like 9 million or so at the base. And then, obviously it only goes higher. I think the complexity is we don't know the rules of engagement right now, and the payers and providers both are struggling with that. So as these new workflows are established and these new networks are created, I think there has to be some sort of contracts in place where there is more understanding with regards to who will be the beneficiaries and how these rules will work. Because right now, I think the lack of understanding of that is just keeping the business case at a very minimum. And we are only talking about the administrative burden reduction, the cost reduction based on the waste, and not really talking about the actual tangible business gains that an organization like payers or providers can have based on other levers that we're just now looking at this point, because we are so bogged down into just the details of who will be doing what. So it's sort of like an entry point into a new world, but we're all very nascent into this.
Yeah, I'd just like to pick up that thread. I think that it's really important to think about the economics of this holistically, and I think a lot of healthcare is very siloed. You're looking at, this is I'm spending the money here and what's happening to, and I'm spending the money on the drug spending, spending the medical. But I think if we can think about this, if I keep this patient well, it's good for them, it's good for all, it's good for society financially, right? We are all saving money, and just being able to kind of think about our dollars in that way. I also think when we think about this financially, I seem to want to get myself fired by the end of the day today, but I don't know if we have any South Park fans in the audience, but yes. Does anyone remember the Underpants Gnome episode? Anyone? Okay, I'm embarrassing myself, but that's what I do. Okay, so if we will recall, their business model was step one, underpants. Step two, step three, profit. And I feel like that's how we think about this, right? We have automate, but the step two is the work, right? And none of us, we want to get to the profit part, right? But we don't want to do the step two. And folks, the step two is going to take a lot of time. It is a lot of time, it is a lot of work, and it's a lot of money, but I have to believe that it's all worth it. And as patients, it's worth it for all of us, but we're gonna have to do the step two. We are better than underpants gnomes. Who's gonna go get that tattoo with me tonight? No.
Well,
maybe not, but.
And to pick up on that, when I think about how, for your model, how does this work with NCPDP? It's because we're doing multiple things with the same connection. If we build a system that's just for prior auth, all we have is a system for prior auth. What is the payer-provider data exchange that we want and need for eligibility, for utilization management, for connection to payer programs? There's all sorts of things that we should be thinking about. One of the things I learned in government from some of my interoperability friends is if a problem is too big to solve, make it bigger. And because you bring in more resources, you bring in more ideas, you bring in more use cases. And so how about if we solve the payer-provider connection problem, not solve just a prior authorization automation problem?
I told you all this was going to be a fun session. Notice that we have no table in the front to prevent us from, not having stuff thrown at us. But I do want to add just two to three things to what you said, Heather. So when you think about the ROI, it's very easy to say, well, the ROI is just going to be a reduction in FTEs, full-time equivalents, that is, for an administrative, standpoint. But it's not just that, right? And when you look at the NCQA data and how we're looking at how we're measuring the adoption of EPA and the costs associated with it, we're only looking at just the tip of the iceberg, which is the transaction costs. But you have to look at, it's huge. If you really want to do a true ROI analysis, you have to look at all the aspects of the administrative element of that, but there's also the clinical aspect of what is the total cost of care, and is there a total cost of care reduction? So I do think, just to kind of round out this question, there's the implementation, of course, that's where the rub is. There's, what do we do about the standards, and can we agree on that? But it's also, have we really fleshed out the business case? Are we looking at all the elements of that, or are we only just focusing on one aspect of it and not really painting the broader picture, to your point, around not just the reduction but also the gains from a total cost of care and other things that we will discuss. So with that said, I do want to get into the AI portion of this, of course. So the next question is, do you think Gen AI is going to change this, or is it going to add more complexity? And I want to go to you first with that.
Yeah, so if you were at the last talk, you kind of heard me say that we already are using Gen AI to do appeals letters from the provider side back to the payer. And again, with this idea that what we might eventually have is your bot talks to my bot, talks to your bot, talks to my bot. And then we haven't solved any problems, I don't think. We just have created an echo chamber of chaos. And so if we focus only on the current way we do things and try to just reproduce that electronically, we will continue to have a mess that we're not happy with. It'll just be a more complicated mess with more technology. So how do we think about what's simpler, what's different? What can we actually eliminate? And I do think that there is an opportunity for AI. One of the things that the generative AI is good at is digging through lots and lots of text and data and finding the things that the prompt is asking for. Now, we're going to also be able to trust that. That's going to take a while for us to trust that, but that's one of the things it's good at, and that's one of the hard tasks if you've ever had to do prior authorization justification. It can take you a long time to dig through lots and lots of the record to find the few things that you really need to submit. So I do think there are opportunities, especially if we focus on what's actually valuable. But there are risks that we will just create a bigger mess.
And I do want to bring up, this is almost like part two of if you sat in the previous session. When you think about, and it's not just traditional AI, but Gen AI, you have to think about all the capabilities that you have to bring to the table to be able to not just implement, but operationalize. So I did want to bring your point forward in the last session around machine learning ops or ML ops, AI governance. A lot of people think that I'm just going to implement this thing and I'm done. Like I flip the switch and I'm done. But actually, with these technologies, the model changes every single day. It's constantly changing. So you really have to think about, what do I need to have from an operations perspective to be able to manage and, reputational risk, clinical risk, there's all sorts of elements around that. So I wanted to kind of bring that point forward. And with that, Tamkeen, I'm going to ask you to weigh in.
Yeah, I think I'll weigh in on one part on technology front, and then the second one is obviously the operation side of it. So on the technology side, tremendous opportunity with Gen AI when it actually comes to prior auth, because the biggest problem with prior auth is the amount of data, as we talked about. And for us to have an opportunity to train models for your particular organization and continue to improve is a huge, huge thing when it comes to really using technology as an enabler. The other portion of this is, and there's some work that we are ideating on, is there's a really compelling business case that if you do have a good standardized data, I would use FHIR, it could be many other type of standardized, it really improves the model, obviously, right? There was a previous session that we talked about the hallucination or the where AI doesn't work is if you are feeding in garbage in, garbage out sort of mentality. So if you have a standardized cleansed data that you are feeding, you're just only making your models efficient. And that could be a huge gain when you are taking a problem bit by bit and working towards your organization. It could be a long-term gain. So from a technology roadmap perspective, I think there's a lot of potential. On the operation side of things, going into and IBM has spent a lot of time talking about the trustworthy AI, the ethical side of things. And essentially, you're not eliminating people process tech data. You are just enhancing it with the new technology that we have in place now. So the human element will never go away, it'll just change. And you cannot overstate the importance of oversight from a human to execute this whole spectrum. And that's really where what Eduardo mentioned from governance standpoint comes into play. So I think the model doesn't change. How we deal with it, like with regards to an enterprise, is certainly going to change in the next 5 to 10 years for everyone.
So with that said, I want to bring it to Heather in terms of your perspective, in terms of AI in prior auth and sort of the considerations from the AMA around that.
Sure. I think there is, with all these technologies, the potential, but I think a lot of our concerns, what are we training machine to do? Are we training, is the machine learning to make bad decisions? That would be a disaster, and that's what the oversight is necessary for. If it's, if it keeps learning every day, but it's being trained to do denials, I mean, that's certainly not what physicians want, but that's none of us as patients want, right? So I think the oversight is definitely really important. And again, I get back to step 2, the underpants gnomes, which is apparently what I'm obsessed with. But to your point, Kevin, is that so I agree that the potential to scan and look for the key points, but then, and then maybe this is not, I'm not sure if this is exactly what you're pointing to when you're saying being ready to program all the rules. How we build everything out to pull out for every single rule for every single payer the data you need. Step 2, that work still needs to be done. Yes. I don't care if you had the surveillance to do it, but for every single service that needs prior auth for every single payer, you need to build out every piece of data that you need, and that is the work. I don't know how you get around that. No matter what fancy thing you're building, you're going to have to do that work, and volume reduction is going to have to be part of it for this to happen, because it's just too much work. or else we're never going to get to step 3 profit, and the gnomes are going to be very sad, Eduardo. That's what I got to tell you today.
So with that said, I do want to kind of bookend that conversation with, making sure that these are considerations that you have to keep in mind, right? Whether you be a payer in the audience or a provider in the audience or a regulator in the audience, right? It's the complexity, and I think that's what's really nice about it being here at WEDI is that we can talk openly about the complexity and really have a candid conversation with each other around what that means. So I want to transition into the EHR. So the holy grail, it seems, for prior auth is to be embedded in the clinical workflow. And it's been said over and over again this week, and it's where the majority, and I've spent quite a bit of time looking at solutions in the market, and IBM's creating a curated sort of ecosystem of partners, solution partners in this space to really help understand, what is the actual true innovation that's happening out there, considering that when you just put prior auth and solutions in your favorite search engine, there's 250 plus every single day, something new, right? So most of the solutions that are at the forefront are really looking at that EHR integration, and there's a multitude of reasons why, obviously from a usability standpoint. But I want to talk about, okay, if we do that, what are some of the pros and cons with embedding yourself in the EHR? And what are some of the guardrails that, again, maybe there could be a solution vendor in the audience that's thinking about going in that direction, or a payer who's thinking about introducing perhaps a Smart on Fire app that a provider might want to use. So what are some considerations when you start getting into the clinical workflow? And I want to start with you on that and then go to Kevin.
Yeah, sure. So I think overall, the idea of integrating with the EHR workflow is really important, and it's what physicians want. I think from a payer point of view, I understand that the portals are helpful and represent automation, but they don't really do a lot for physicians because they're different for every single health plan that they do business with. It requires a different login, a different password, re-entering data from the EHR. That's not really helping out the provider a lot. So that EHR integration is really important from that point of view. And also, just from getting that information at the point of clinical decision making right there in front of the physician, so they know what, if we're talking about drugs, whether it's preferred drug or whether or not prior authorization is going to be required, so they know that prospectively, right? That's really important. So we see the benefit there. I think there are some potential pitfalls that I think are important to keep in mind. First of all, I think this has come up in some of the Da Vinci discussions, the idea of, are we making the actual physician do more work than they're doing now? And I'm sure we all know as a patient, we want our physician's attention on us during those, like, however many minutes we get in front of them. We don't want them, interacting anymore with the EHR. And so if there are tasks today that are being delegated to back office staff, we want that delegation to still be able to happen, because it's not going to help physicians that are doing more actual administrative work, as a result of what we're building. And also there are concerns about this idea of, the payer EHR connection and kind of the maybe paranoid thinking that comes along with that, but I think it's a real concern. What data are the payers going to be able to access as we build this all out? And is there the potential danger of payers getting access to more data than they need to process that particular EHR, which is very concerning, certainly from a physician point of view, but as a patient, right? And then, so physicians, we certainly want to maintain autonomy over the EHR data, control what's going to the payer, but they also very much want to still remain autonomy over the clinical decision. I mean, they want to, the payer will see what it is, but they still, at the end of the day, want to decide what's best for their patient. So I think it's important to keep those two autonomies in mind as we're talking about all this.
And then Kevin, you build CDS systems.
Yes.
So where's the line drawn between payer provider in this regard?
Yeah, no, a lot of thoughts here. So one of the things we haven't talked about very much is the patient. And as a provider, one of the most irritating parts about prior authorization is when I make a plan for a patient and we can't actually execute it that day. Like, somebody needs this thing, they need this scan, they need this surgery, they need this medication, and I've got to tell that patient, I can't let you know today if we can do this, because I've got to do this other stuff. And by the way, there's a bunch of waste in the office in tracking all that and paying attention to all that and doing the back and forth with the patient as they're waiting and waiting and waiting, and we're trying to figure out what's going on. So from getting a real-time decision, to my mind, is more important than the EHR integration. The EHR integration is a path to a real-time decision, and it's a path that can work. The state of Minnesota, where I was a CMIO, implemented the first version of the radiology decision support and we got waiver of prior authorization from all the payers in the state in order to do that. I thought my providers were going to hate it. They loved it, actually. They were really happy because they finally didn't have to do any prior auth for radiology, and they got some feedback that said, this particular scan isn't the right scan for this patient. Do this other scan instead. So it wasn't a no, it was the evidence tells you, the radiologist tells you, this patient shouldn't have an MRI, they should have a CT. Well, that was great for everybody because the patient didn't have two scans, the payer didn't pay for two things, the radiologist didn't either have to do back and forth phone calls or they didn't have to do a bunch of other stuff. So what's the problem we're trying to solve here? We're trying to get the right tests, the right procedures to the right people that's aligned to the evidence. Like, keep the eyes on the prize on that particular problem. And a lot of the other stuff, if we build the back end right, will follow. So one of the things my team is committed to doing is being very clinically focused first. We're giving medical guidelines, things like the American Heart Association guidelines for heart failure, to the provider. It's agnostic of payer, it's agnostic of rules from the prior auth utilization management standpoint. This is what the scientific consensus says about the evidence. We strongly believe that evidence is mostly what all the payers are using primarily for their prior auth. And if we can help our providers make really good evidence-informed decisions, they're gonna have much less exposure to the kinds of things that would require prior auth. And some of the people that kind of built this have had success in the cancer space, building tools where if the provider is choosing a cancer treatment therapy, and we can show in the data from the EHR that it's aligned to the guideline, you don't actually need a prior auth. You can just send a report to the payer and say, hey, look, here's the data. This is the clinical input that helped that provider decide which of these cancer treatment to have. By the way, there you go. And eventually you build trust and you're kind of a gold-carded provider because you have repeated data that says you're always in guideline-directed therapy. That's what we all want. Like, prior auth is just a means to try to get to the right thing for the patient.
And just to kind of end on what are the actual takeaways of that before we talk about, something positive that we can all walk away from at the end of this discussion. But what you're saying is, from a payer perspective, the opportunity of being in the EHR is to really potentially introduce the concept of care navigation, right? That's a huge benefit for the payer to be able to do that, during the encounter. But of course, that's provided that you're keeping a safe distance, from the elements that are important in the provider workflow from actually, taking care of the patient. So that's one aspect, as a takeaway of the EHR integration. Think about, from a payer perspective is the care navigation. From a provider perspective, I think we have to, and this is just a thought for everybody, we need to start kind of separating the idea of medical necessity and clinical guidelines from prior auth, right? So, meaning, of course, the process of prior auth is to prove that yes, the care is medically necessary, et cetera, but as a provider, it benefits me if I can see those clinical, guidelines, criteria, whether they come from a third-party source or from the payer or edits or whatnot. So I can have the information to make decisions. right? And that can happen before you even get to the prior auth, right? So if we start looking at those two things as separate but interrelated, it gives us an opportunity, especially on the provider side, to have more flexibility in how you set up your revenue cycle process and how you enable your physicians to interact with that information, and how you can leverage new technology like generative AI to create a conversational interface for the provider to say, so they don't have to sift through 40 pages or 100 pages worth of this clinical policy, but be able to get to the answers that they need to get to quickly without, again, the issue with the technology of, well, I'm using the technology for decision making. In this case, you're using the technology to help the provider find the information that they need faster, not necessarily making decisions on their behalf. So I just want to introduce some of those thoughts. And with that, I do want to do the let's close with one reason why people should be excited about the future of prior auth. And I'm going to start with Tamkeen and work our way back.
Yeah, I think my colleagues in the room will know what I'm talking about, but at IBM, like healthcare interoperability, we're really tied to this map that CMS and ONC has laid out, and that is, the long-term view of how these building blocks will come into play to really do whole person care, essentially. And prior authorization is the brilliant basics at the bottom of that roadmap, because it's complex and you have to take like bit by bit. But at the same time, if we are able to solve this, if you are able to implement the technology, the capabilities which are required for prior auth, at the same time solve basic payer-provider interaction understanding, I think the rest of the roadmap will become really easy. So that's really what my pitch is and the excitement about this work, essentially.
So I look to payviders as kind of leading the way here. So the Kaisers and VAs and Indian Health Services and the kind of the global budget organizations are thinking about both the bottom line and about what's right for patients, and they often have really interesting solutions that are not what we've had in our adversarial health plan provider world. So I have a lot of interest in, for example, I came from the Indian Health Service. What did they do? How did they think about this? Because some of their stuff is so out of the box, but it works. And it's already works, it's already live, it's already there. How do we take that and move it into the space that we're in?
And I think I'm kind of tagging on with what you just said, but I think that obviously, the WEDI crowd is all about health IT and electronic transactions, but I think the reason that we can be excited about prior authorization, despite all the frustrations, is that it actually matters. It impacts patient care. I mean, certainly it's important to make all these transactions work well, but at the end of the day, this is your mom, your friend, your dad, your sister not getting care that they need in time, and it's a human issue. It's going to unfortunately affect all of you, and so all of us. And so I think it's the thing to be excited about. We're working on something that's really important.
And I will add to that just a couple things. Again, I would like everybody to walk away from this conversation feeling inspired by the work each of you is doing here at WEDI and the passion that each person brings to the table in terms of trying to find solutions to the complexity that we have. It's the reality of today, but also looking at examples of what payers are doing out there, what providers are doing out there to really push the needle or move the needle forward, I should say. And again, looking at new technologies as a source of inspiration where we leverage that responsibly and also manage expectations appropriately. I feel like in healthcare we have this tendency that every time something comes up that's new, we hype it up so much only to just watch it crash and fail, and then it's a self-fulfilling prophecy. So think about, again, how do we manage expectations around new technology and really allow ourselves the room for failure? Because in healthcare, failure is not acceptable, but in order to innovate, you have to fail. So how do you make those two things happen? So with that, we're going to open it up for questions, and I just want to check if we have any on the chat before we go out with the mics.
It seemed like all of the panelists had the same sort of theme about the payer and provider connection being one of the core issues. And if you could solve that problem, you could do so many other things with data exchange. We also heard this morning from Mickey Tripathi from the ONC about TEFCA and the future of TEFCA. Where do you see TEFCA fitting in? Or, he talked about using that as the public highway. Is it so far away that it's kind of a dirt road and we need something else in the meantime? Where do you see TEFCA fitting in?
So we're thinking hard about that at the UHG. Some of it actually gets back to HIPAA and what kinds of data use arrangements that are allowable for care versus what's allowable for kind of payment and operations. And so we have hundreds of contracts with data use agreements. So even if TEFCA comes, we still have to really be careful that we're doing, not taking the data we get for care and suddenly treating that as a payment and operations data. We have to know that we've done that right consent, we have the right data use agreements for that purpose. So it's a big step forward. Allowing a common agreement is terrific, and having national nodes of connection is terrific. Is it the Holy Grail? It is not the Holy Grail. Were HIEs the Holy Grail? No. Did they actually get us a lot more interoperability? Absolutely.
So with a lot of the payers, they have third-party UMOs that also control all of their authorizations. How do you see them being rolled into all of these proposals and having to basically fulfill the same kind of requirements?
I'll take a first stab at it and then have our panelists weigh in. So there's and I think it was mentioned earlier today around the idea of routing, right? So there's going to be situations where you might want to have, a third party look at, specific clinical specialties because, even if we think about some of the newer types of therapies, it's not just the I submit the prior auth and I'm done, right? It's first of all, there's the medical, then there's the pharmacy, then there's the DME, and it all has to happen together. So again, expectations around technology. Is technology actually going to be able to, do away with the third parties? Probably not, right? But what you have to look at is where am I, if I have a bunch of tools sitting in front of me, what is the right one for the right problem, right? And where do I get the most efficacy out of that? And maybe in a particular clinical specialty, there might be a third party that, does it really, really well for a very reasonable cost, and it's their problem how they want to automate, not automate, or address. It's part of their business model, their business case. So we have to think about, it's not just I pick one thing and that's the one thing that's going to fix everything, but really looking at it more like a portfolio and looking at, okay, where do I have the most efficacy and where should I really invest when it comes to, automation?
Yeah, we have one of those UMOs at Optum, Utilization Management Organization. Part of what we're doing is how do we better connect that to care management? How do we do care navigation? How do we, again, be member-centric here and not have a sort of separate utilization management function, a separate care management function, a separate navigation function? How is that a member-centric support and with the right kind of steerage that the plan that we're working on behalf of wants us to do that steerage?
And I'll just pop in from a physician perspective. I think it's really important that all of those relationships, which were obviously everyone's business right to set up a relationship, should be invisible, right? Whatever y'all do, however you do it, fine, but I ping you and it goes where it needs to go, and because otherwise it's a mess. And I think, there's a huge problem now, but certainly whatever technology we're using, that it needs to go where it needs to go. And I know some of the discussions with the Da Vinci guides, I know that's come up lately, that discussion's kind of still circling around a little bit, and it's a challenge and it needs to be figured out or it's going to be really frustrating.
And I do want to add one more thing. And again, going back to the point of the EHR integration and the Smart on Fire apps and so on, don't forget about usability, right? If each Smart on Fire app looks entirely different, then you're doing nothing different than a portal, right? And where a portal is, different data being requested, different look and feel, different this, different that, right? And again, if I'm a provider and I'm looking at my revenue cycle process, maybe I want to use a revenue cycle suite that integrates that so I can have a consistent experience. So I may not want to use payer ABC's, Smart on Fire app. What I want is I want that to be handled in the background. I don't want to see it, right? However, the nice thing about most of the new solutions is you can start surfacing information through those Smart on Fire apps, like whether it be a care navigation component or other information. So think about how you integrate. Again, if a provider is using already a revenue cycle suite, how do you integrate with that versus assuming that, well, I have my Smart on Fire app, so they must use it. Just like saying I have my portal, and they must use it, right? So providers do have choices, so we have to keep that in mind.
Any other questions? I have one. Go ahead. And then I do have one. Oh, good. I can use my microphone. There you go.
Well, it is kind of a general question, but are there any EMR vendors in attendance at this event?
Are they hiding somewhere that we don't know?
Because to the points that you were just making, the Da Vinci spec is designed such that all the workflows are initiated from the EHRs, and so all of our solutions are dependent on that functionality being there, with the key DTR app piece being the common one that the providers can choose, so all of their clinicians can use one interface, to your point. So the spec is designed for it, but we're kind of all hostage to those buttons being in the EMR. Or somebody building a solution that might get wiped out by the EMR doing that.
They were very much part of building the Da Vinci implementation guides, having been on those groups. Like the EMR vendors were very, very present. They've had a number of connect-a-thons. They're also very used to responding to CMS regulatory requirements around adopting new implementation guides. So, are they instantly all going to be able to do this perfectly? Of course not. Have they been in part of the process? Absolutely.
This is where the enforcement will come into place from. This is where it's important for the regulatory bodies to be active in this, because different entities within healthcare may or may not have incentive to be the player at the table, but then when it's being enforced, obviously it changes the spectrum in how you move forward, essentially.
Sure. I'm not sure if you guys can answer that question, but given the complexity of automating prior auth against the proposed requirements, and then where we're at today, do you foresee the compliance deadline remaining January 1st, 2026, and the scope to continue to include specifically the DTR and PAS components that seem to be more complex, more challenging, require more vendor integrations, et cetera?
I want to take that one. So according to you all, according to the audience, the answer is no. But that being said, I think there is a lot, and again, I really loved the chart from Massachusetts on here's the requirements, payer, provider, intermediary, et cetera. But that's just the tip of the iceberg. I spent some time, IBM put together a reference architecture for prior authorization. Again, helping think for our clients, what do I need to be able to do all of this? Like if I need to comply with 1126, okay, how do I work backwards, right? First of all, what are all the requirements? So we went out and captured all the requirements from the CMS rule, from every single state. And then, okay, now we work backwards from that. What are the architecture principles that are going to be required? What are the patterns that are required? What capabilities are required? And again, it's not here's my point solution and I plug it in and it's going to fix everything. You actually need, I think it's it keeps changing, but it's over 80 capabilities that you need to actually be able to do this. Like if you really want to think enterprise architecture, what do I need to be able to do this for 1126? It's over 80 capabilities, over 200 requirements, over 15 architecture principles, et cetera, et cetera, et cetera, right? So I would encourage everybody, again, if you're looking at the deadline, look at where's my architecture? What do I need to have? And is it comprehensive enough, or am I only looking at, and again, I'll go back to the Massachusetts example, which was great. Here's what you need, but this is just one layer of the architecture. You need operations, you need DevOps, you need infrastructure, you need security, you need network, you need your channels, and all the different varieties of channels that exist out there, all your core systems, right? So you really have to think broadly, and with that, I think maybe the challenge to get to 1.126 might be underestimated. And it's of course going to vary whether you're a payer or a provider, but again, I would encourage people, maybe starting January 1st, maybe your New Year's resolution, sorry, get your architecture people together and say, okay, put something together for me, help me understand what do I need to do, and what do I have today that I can leverage? What am I missing? Do I go out and buy a point solution? Do I go out and build something custom? What is the TCO? What's the potential ROI? I would, if I was sitting on the business side and I was looking at that, I would engage my IT counterparts and say, give me a plan. Give me a plan, tell me how much it's going to cost. I want to understand all of that.
Who here lived through the ICD-9 to ICD-10 transition? So the sky was falling. There was no way we were ever going to do it. We needed to delay. CMS delayed a couple of times, but eventually they just put a line in the sand and said it's going to happen. If I look at, I think this is going to be in a similar place. There is some room for delay, but eventually it's going to be like that. There'll just be a line in the sand, and they're going to say, this is the line, and we're going to draw it. We can't know that from the outside. I will say that there are opportunities. If you've been following price transparency, you know that they mandated it, but then said they're not going to enforce it, right? So there are a number of ways that they can do this, draw a line in the sand and say, yes, this is the reg as of the state, but we realize the complexity, and therefore the enforcement will be gradually enacted. So if I were going to read a crystal ball, I would say it's going to be something like that. Whether it's 1.126, I don't know. But looking at their kind of path and how this has happened, it will happen, and it will be a date, and there will be some kind of repercussions, but also likely some kind of realization that this is, you don't just flip a switch and tomorrow everything changes, that there is a phased enforcement activity.
Not to mention that we have to fix attachments. Where are all the attachments? Oh, sorry. Where are all the attachments people? Raise your hand. Go fix attachments first, then we can talk about 1.126. Do we have any other questions? Awesome. Well, I hope you enjoy this. This was really meant to be a candid, open conversation. And again, just kudos to everybody's efforts and really, moving the needle forward.
So maybe we can promise the next episode will be unpacking step 2. That was suggested.
Oh my goodness. We absolutely need to do that. Thank you, everybody.
Next episode.